Hello, all. Thank you for joining us today. My name is Michelle Wagner. I'm with NAMI New Hampshire. This presentation is brought to you as part of the Onward NH webinar series, which it supports the First Episode Psychosis Early Serious Mental Illness Initiative. Thank you for joining us for today's webinar titled Medication Selection for the Treatment of Early Psychosis Using a Person-Centered Approach. This presentation is being recorded, and you'll be able to find it on the education page of onwardnh.org. In the next couple of days, you'll also receive a follow-up email with links to both an evaluation and the recording. This is a Zoom webinar, which means your camera and microphone are off. The chat is working, so pardon me, the Q&A is working, so please enter any comments or questions there, and my colleague Meredith Closey will help field those questions. So today we're talking about an important topic for those in need of antipsychotic medication. So joining us today to share her expertise is Dr. Melinda Asbury. She is the Chief Medical Officer for Monadnock Family Services, Mental Health Care, and the Chair of Psychiatry at Dartmouth Health Keene Cheshire Medical Center. So Dr. Asbury, welcome.
Thank you, Michelle. Thank you so much for having me. And thank you, everyone, for inviting me today and letting me be a part of the community.
Yes. So Dr. Asbury.
Oh, go ahead.
I was just going to say, do you want to tell us what brought you to the mental health world?
Absolutely. And I do want to first apologize. I know that this had to be rescheduled for today as opposed to last month due to an illness I had. So thank you all for your flexibility, and I apologize profusely for that. And thank you for joining us today. And Michelle brings up a great point, right? Why do we all do what it is that we do every day? And for me, this was a very easy decision that I had of why to go into the field of psychiatry and why to specialize in the treatment for individuals who have had psychotic experiences or who are at risk of having them. My favorite thing about my job and the reason that I went into the field is I do like to advocate. I like to help others who, are more vulnerable, or people who have, for no reason or fault of their own, have different challenges than what others may have. And I find the role that I have a privilege in order to be able to work with the individuals that we get to work with every day. So that is the why. And I, again, just appreciate you all having me here today for this talk.
Great. Thank you, Dr. Asbury. So we will now have you move forward with your presentation.
Great. Thanks again, Michelle. So as Michelle said, my name is Mindy Asbury. I'm the Chief Medical Officer at Monadnock Family Services. We are one of the community mental health centers, and we serve the greater Cheshire County and some of Hillsborough County in the state of New Hampshire. And I also work at the hospital where I'm the chair of psychiatry. My background, though, what really drew me into this field, and I think one of the reasons Michelle reached out to me, is that I have spent my career doing both assertive community treatment, so on ACT teams, as well as working in first episode psychosis programs. I was the medical director of one of the first episode psychosis programs in North Carolina, and I had the opportunity and privilege to open 2 other FEP programs across the state. So this is something that has been very important to me in a population that I absolutely love working with. I do want to give a caveat at the beginning that there are different types of models to follow, if you will. It's jargon and scientific for the treatment of individuals experiencing early psychosis. And this is not what this talk is. Okay, so this is the Mindy Asbury, what's worked for me, mixed with data and literature, but just a combination of things. So just want everybody to level set with me. Disclosures, I have no disclosures since October of 2023, so no one's paying me. I don't get paid by anybody for anything, so this is just me, raw me here. So let's go through our objectives and let's level set a little bit, right? So let's understand what the goals are for today, what my goals are for today, and see if we can't accomplish those by talking together. So the first thing is let's learn as much from one another as we can. And in part of that, I have a responsibility. And for me, my responsibility is to avoid jargon. It's very easy for doctors to use jargon all the time, avoid heavy data, and to focus on a more practical approach to medication selection. So that way we all can help all of the clients that we work with, no matter what our role is in that, because we all have various roles that are of equal importance. And so your job in this is to ask me questions if I'm not clear, and also to share with me your experiences. I'll ask a lot of questions throughout this talk, and I know my answer, but I'm not as interested in that as hearing what your answers are and having others share and hear your answers as well. Provide a general understanding of what and when to treat individuals who may be experiencing early symptoms of psychosis, how to select for medications, an emphasis on using long-acting antipsychotic medications, so injectable medications, as well as clozapine, and then building a lasting relationship, all of us together in our New Hampshire community. And again, thank you to our colleagues with NAMI for setting all of this up. Very, very fortunate to have them as colleagues and partners. So first, when and what to treat. So let's start first with the when. So I think it's important if we start out and we acknowledge, this is a surprising figure to most people, that about 9% of adolescents and young adults actually experience perceptual abnormalities. Most of the time, these are visual disturbances or auditory or hearing disturbances, where individuals may hear or see things that others can't hear or see. We often see this in general anxiety. So it's not uncommon for people who have struggles with anxiety to actually have hallucinations. Social anxiety, a lot of the times, can present itself as underlying paranoia. Someone may seem to be paranoid, or they may have feelings of paranoia, but it's actually not terribly abnormal in social anxiety to experience those things, especially in younger populations, younger folks, as well as a history of trauma. And the reason that I bring this up, I want there to be the awareness that almost 10% of our youth have these experiences, because it's important that us as providers and thus as other caretakers and members of teams recognize that it's not recommended to treat those types of perceptual disturbances with antipsychotics unless there are other symptoms present. So let me say that again. For this level of symptoms that individuals who are the youth have, we typically do not recommend treating them with antipsychotic medication at this point unless there are other symptoms. And the reason is that some of the literature out there suggests that when we treat with antipsychotics, when someone's not fully psychotic, if you will, yet, that we can actually cause psychosis to set in. Now, that data is probably a little bit flawed because it probably selects out people who may have developed a psychotic disorder anyway. But I do want to say and just drive home the message that when these symptoms are first starting and there's not other symptoms with them, we don't want to move to treat. We want to move to support. This is heavy for providers, but the exception on that is if there is a hallucination-delusion relationship. And I know that's jargon, right? So I'm going to explain that. So when we do want to move to treat is if someone is having a hallucination and the explanation for that is a delusion. So they may make up a story or say something that explains they're having a hallucination. When that happens, we do want to provide treatment to the individual. All right. So the when, right? So when do we start providing medication for treatment? When do you, as people who work with clients or family members, know when it's time to get some treatment and what that treatment is? So if some people have something functional impairment, and that's in quotes because it's jargon, but what that can look like is struggles with academics or school, struggles in job, struggles with personal relationships or friendships, or struggles with, taking care of oneself, maybe not showering and cleaning as much as often, maybe having a little bit dirtier of a kitchen than what one normally has. When we start to see those things, we call those functional impairment. And when individuals start to have that, and they have those sort of lower, hallucinations like we were talking about, then we want to think about, okay, like maybe we should start moving towards treating with something. The other time is if we know that someone is what we call an elevated risk of developing a psychotic disorder. So this would be someone who are having these soft level of symptoms, and maybe they have a family member who has had experiences of psychosis. Then we think that, okay, this person's at a little bit greater risk, so we should probably think about, treating sooner rather than later. And the main thing, right, what we really care about and what we're all here to do together is to make sure that the individuals that we work with, that we care for, if they are having any bothersome symptoms of or distress, that we treat those and take care of those, because that's at the end of the day is what matters. So when and what to treat. Let's talk about the what. All right. So before we do that, let's take a look at the stress, tolerability, resiliency model of psychosis. I know that's a lot of jargon, but I'm going to break it down and explain it to you. All right. So we talked about when, right? So when do we think about starting to treat with medications? And now we're talking about, if we do treat, what is it that we target? All right. But what we want to do first is understand, why are we even treating? Why are we even working to reduce the symptoms or struggles that folks are having? So if we look at this, I know it's a little bit heavy, but I'm going to explain it, okay? The whole principle of moving to help individuals and finding them treatments is so that we can build up resiliency. All right, so let's look at that. So what we have demonstrated here is over here, we have stress. So the higher we are up here, the higher stress someone is experiencing. Okay, this can be stress to anything. We all experience stress every single day of our lives. And down here is lower stress, all right? And on this little line here, what we have is high resiliency. And this is when people have a lot of skills. They have a lot of coping skills. They're good at working through challenges or struggles. They have a lot of family support, which goes a long way. They have natural support. And we call that resiliency. On the far end of resiliency is what we call vulnerability. In other words, things that can cause stress to be even more impactful than what it might be to other individuals who don't have as high vulnerability. And sometimes genetics can play a role in increasing vulnerability. Sometimes it's life experiences, trauma. So there are a lot of things that increase vulnerability. So what we have is a little curve here, all right? So what this says is that people who have high stress, but they have high resiliency, probably are going to have no or mild symptoms of, something similar to psychosis. So we follow down this curve. But as we get to individuals who have higher and higher vulnerability, then we start to see that it takes less stress to have moderate or more severe symptoms, okay? So on this side, we've got no or little symptoms, and over on this side, we have moderate or more severe symptoms. And the difference is here about resiliency and vulnerability. And so this is why we treat, and I'll go over that in the next slide, of all the different ways that we can help to push this curve over a little bit. And I'll also show you a picture of that. All right, so same thing. I just made it a little bit bigger, a little bit wider. All right. So we have the stress, high resiliency, high vulnerability, and then when someone does not and does have symptoms. But I pose to you, what if we did this? All right. What if we helped people increase their resiliency and lower their vulnerability? What would that look like? Well, let's look. All right, we would get rid of how that normally looks, and we would actually push this further out. So that way, people who normally, when individuals are here, they can actually have more stress and not have symptoms and have less time having moderate or severe symptoms. And so this is sort of the model we think about, is that when we build more and more resiliency, there's going to be less and less time until we develop or someone develops symptoms because of stress. So another way to look at that is like this, all right? We want to reduce the stress and reduce vulnerability, and we want to increase resiliency. And the reason I keep talking about this is the framework that we use to treat. And so no matter what your role is, this is a way that we can communicate with persons that we work with to put it in a way of understanding of why it's important to treat. So could anybody give me examples of how you or someone you've worked with brings down their stress and therefore vulnerability? Anybody with any experiences with that?
Let folks put that in the Q&A if you would.
Okay. So I can't see the Q&A because I'm sharing, but hopefully there are folks putting some things in.
Exercise, CBT for psychosis.
Loving it. Loving it. All right. Very, very smart group. I feel like I don't even need to be here today, Michelle. This is great. I'll just exit my talk early. Right. Absolutely. So exercise, healthy diet, relaxation techniques, self-care. So everything that can lower our stress can also help lower our vulnerability. On the flip side of that, how do we increase resiliency? Somebody said it, CBT, 100%, very effective to helping build resiliency. What are some other things, if folks don't mind to put that in the chat, please? Have I stumped folks, Michelle?
I think it takes folks a second to type too.
Okay, no worries. All right, just for the sake of time, because I'm very talkative, I will move on and just, put the suspense aside. So skill
Developing,
building. Oh, sorry,
developing,
Michelle.
developing coping mechanisms for clients.
Look at that.
Medication.
Yes. It is as though people have read these slides. I love it. Yes, yes, exactly. And it sounds like this is what's working for people. I know we have a wide range of folks joining us today. So thank you for chiming in, because this is coming from what you have seen, what you have experienced. And you're right. So skill building, cognitive behavioral techniques, social connection and support. And really also a fundamental part of building resiliency is instilling and having hope, belief, and optimism. That goes so far. And that is one big piece of our job, is to help the folks we work with have that and feel that, because it is fundamental to our folks and helping everyone that we can who are experiencing these symptoms. And medication, right? Medication. And I put medication in the middle because it can do both. It can actually lower the stress and the vulnerability, and it can increase resiliency. And a way that I like to talk to some of the individuals that I work with is that the medication is altering the biology, because it alters the brain. And so by altering the brain, it allows people to handle stress or experience stress a little bit better, lessens the vulnerability, and improves resiliency from an anatomy standpoint, actually changing parts of the brain to do that. So we have cognitive, we have social, we have internal processes, and we have medications. All of them is equally as important as the other. All right. So back to treating the what and the when. So what are we treating? So we are using medications, if we're talking about medications, to target those who are at risk of developing psychosis. So maybe they have those sort of softer symptoms, but they're not yet quite at a place of having psychosis. What we want to treat are those anxiety symptoms. We want to treat those trauma-related symptoms that sometimes can cause these very mild perceptual disturbances. And we want to treat depressive and mood instability symptoms. So when we have folks who are experiencing anxiety, trauma, depression, mood instability, and they're having some of those mild disturbances, we do want to treat them. And what we want to treat them with is an antidepressant, not an antipsychotic, like I said, okay? An antidepressant. And this is for folks who are at risk, but have yet to develop psychosis, full psychosis. And if you're thinking they're sort of up and down in the mood, then my recommendation and the recommendation is to use a mood stabilizer instead of a antidepressant. And what we actually know based on the literature and the data is that when individuals are treated with one of these medications, this SSRIs, it actually lowers the risk of them developing a psychotic disorder. So it is prudent that we do help individuals and start treating them with these medications when they're experiencing these symptoms and they have some of those hallucinations or disturbances, right? And so that was for those at risk. What do we target for those who have early or first episode psychosis? So this is going to be different, right? The psychosis is already there. So what is it that we're targeting for these individuals? The same things in part, right? We want to lower the anxiety symptoms. We want to lower the trauma symptoms or the depressive symptoms and treat the mood instability because this is distressing for folks, right? So we want to target and treat these. But of course, we also have to target those antipsychotic symptoms. A question I also often get asked, and I think it's a great question, so I'm just going to put it out here. Of course, we treat with the antipsychotic medication, like I said, but then people ask, okay, well, if we're treating with an antipsychotic medication, do I recommend to the person I'm working with, if I'm a peer or if I'm a counselor or if I'm a provider, that we also treat with an antidepressant because they already have psychosis, Mindy, and you just said that helps them not get it. So what if they already have it? Well, it actually, the literature shows and says that when we do treat someone with an antidepressant or mood stabilizer who has psychosis and they need that treatment, then it actually helps them to stay out of the hospital longer and helps with what we call negative symptoms. So in other words, sometimes when folks have psychosis, they will have a little bit less motivation, feel down, maybe not take care of themselves as much as usual, maybe not be as talkative as usual. And what we know is that sometimes SSRIs, these antidepressants, can help with that type of symptom. All right. So we talked about the when, right? So when people are having these early types of symptoms, we talked about what is it that we target to treat? And those are shown right here. Now, the other part of it is the how to. So how do we select for medications? And this is simple. It's very easy. This is the easiest part of the whole talk, all right? So which medications have the best evidence or are shown to be the best to support their use? And this is for the treatment of anything, all right? This is the most important part of it. The best medication that's got the best evidence is the medication that works the best for that particular client with the least amount of side effects for that particular client and the medication that that particular client prefers and wants to use with the information provided to them. So this is all person-centered. You may have in mind what it is you want to provide or recommend, but it all matters what works for the client, what works for the person. So that's just the most important message of this talk. But this is one of those talks that I get to be a geek a little bit on, so I'm going to geek out here. All right. So for those of you who are, more data-minded and things of that sort, and those of you who have the interest and work with, with our population, what is the best medication? So if we were going to look at the literature to talk about this, and I have this jargon, and I promised I wouldn't use jargon, but I didn't have room on my slide, so forgive me. So an SGA, this is an antipsychotic. That's what the A stands for. An SG is second generation, so sort of a newer antipsychotic medication. And the FGA, since this is second, you probably guessed it, this is first generation antipsychotic. So these are the older ones that were first developed. So what we're going to look at is which kind of medication actually says works a little bit better for our friends who are developing early symptoms of psychosis. And what we know is that the second generation, so the newer medications, these SGAs, actually have been shown to be better at working with those negative symptoms we talked about. So that low motivation, low mood, not talking a lot, maybe not caring for oneself as much as usual, as well as cognitive symptoms. So how someone thinks, how they plan their day, how well they remember and retain information. So we know that the second generation works better for these types of symptoms than what the first or older medications do. This type of medication, this newer generation, it also causes less tremors, less stiffness, and less unwanted involuntary movements that the client is not wishing to have. The tremors and stiffness, for those of you who like the terminology, this is extrapyramidal symptoms, EPS. And these, what we're talking about, is tardive dyskinesia, or TD. And so these newer class of medications cause less of this than the older class. Now, I'd say the good and the bad, right? So you got to present it both ways. So, however, the second generation of medication actually can cause more weight gain than the older medications, and it has a higher risk of people who are on it developing diabetes, high cholesterol, or high triglycerides. And the reason this matters is a lot of times when, it causes death earlier sometimes. So it matters a lot for a lot of reasons. And so we really have to be mindful when we put and think about treating individuals with these medications that we're addressing the weight gain, addressing the risk of diabetes, cholesterol, and high triglycerides. And we talked previously about hope and confidence. And one of the things about weight gain that can happen, and I think our society is getting better at not doing this, is that sometimes that can create social stigma. And for individuals who are a little bit younger in life, sometimes that's even more stigmatizing. And so we want to be very mindful of that weight gain and help, our clients manage that and help them to not have as much weight gain as we possibly can. And when we use the newer generation of medications, people are less likely to stop them against medical advice, meaning that even if we say don't stop them, people who use the older medications may stop them early. And the reason is because they have these types of side effects that are bothersome. But people who are on the newer meds, they tend to stay on them longer. And again, we want to do what's best for our client, what the client wants. And so that's why we support a second generation antipsychotic. All right. Now, this looks like, what in the world are you doing, Mindy? You said no jargon. You've got these weird words up here with these years and dates. But I want to highlight something, okay? So there have been a lot of pretty good studies that have been done across time in the United States. One of them being a Navigate study. I'm trained in Navigate, but again, this isn't a Navigate, talk, but this is one type of way that people use to treat. On Track New York is another type of way that individuals use this guidance to treat their clients with earlier first episode psychosis. And then a PORT study, which is Patient Outcome Research Team. Okay, so all of these studies have recommendations of what are the medications that you should use to treat clients who are having these early experiences with psychosis. And if we look at Navigate, it lists them right here. We'll go through them quickly: aripiprazole, risperidone, quetiapine, ziprasidone, and risperidone microspheres, which in other words, this is the long-acting antipsychotic version of risperidone, otherwise known as an LAI. On Track New York has similar but different medications that they recommend. And PORT study has soft recommendations of, they say, whatever you want as a first line, so first medicine to try, as long as it's not olanzapine or clozapine. The reason is we can't try clozapine first. If we could, we should. And then they also have a recommendation to avoid those older antipsychotics for the same reasons that we just talked about previously. Now, the nice thing, though, this is a lot of different things, right, is that if we look at the different studies, especially the Navigate and On Track NY, we start to see overlap between aripiprazole. We see overlap with risperidone, and we see overlap with ziprasidone. And so we see that these two very large studies and something that people are still using have this overlap. This tells us, okay, we must be onto something good here, right? So if we go forward a minute, what we have done since the 2014, 15, 2009 studies that were done on that last slide is that folks like you and I and people who do research for a living, all right, they have studied and studied and studied what are the best medications. And let's come up with a consensus. Now, again, this isn't the recommendation. This is a recommendation that those of you who prescribe medications, or those of you who work with individuals who may be taking a medication, right, have an awareness of what the options and recommendations are. So we have a first line, meaning that if you're going to treat somebody, this is what you should, to expert opinion, start with. It's the same things we saw before: risperidone, haloperidone, and aripiprazole. You will note that ziprasidone is not on this first line, and it was on some of the others, and that's because the side effects can be really significant for some of our folks early on in their treatment and early on with their experiences of psychosis. So it's been removed from a first line. Haloperidone is essentially this medication, risperidone, and it's sort of its cleaned up version. All right. So after risperidone runs through the liver, it kind of ends up being paliperidone. So the makers of risperidone said, okay, well, we'll save the liver a little bit of trouble. Let's just make this one. So they're very similar, right? So you can use either one of those and they're going to work almost the same.
And Mindy, can
yeah.
you just remind us what the brand names are for these medications?
I will. I'm allowed to do that. Okay, excellent. All right. I didn't know, Michelle. So yes, thank you. So risperidone is Risperdal. Haloperidone is Invega. And aripiprazole is Abilify. Right. So Risperdal, Invega, Abilify. Our second line, and what does a second line treatment mean? Well, basically a second line says that the first line, for whatever reason, didn't quite work, or the client said, you know what, I don't want to try one of those. Or the client said, this is intolerable. I can't stand to take that medication. Okay, so what do we move to next? We move to ziprasidone, which we talked about previously, right? The Navigate and New York are saying this is a first line, but again, those side effects can be bad. So we've moved it to second line. This is Geodon. Quetiapine is Seroquel. Olanzapine is Zyprexa. Haloperidol is Haldol. And perfenacine, oh my gosh, Michelle, I don't know, the Trilofan maybe? Don't hold me to that. I've not used its brand in a long time because it's been generic for a while. But
Meredith can look it up for.
Okay, yeah, thank you, Meredith. Thank you. Tammy Dutilli, if you're on here, look it up for me, please. Perfenacine. And these two are first generation. So just keep that in mind, that they're going to have a little bit different side effect profile. But if you're finding that these cause too much weight gain, or somebody was quickly developing diabetes or high cholesterol, that's when you may want to try one of these first generation medications. And then alternatives. And, you know, questions probably like, Mindy, what do you mean by alternatives? You already given me first line and second line. Well, what we are saying, or what I'm saying with this, is that the alternatives are medications that have shown promise, but they haven't been fully studied yet. So people are like, okay, we think they're going to work pretty good, but we can't get fully behind them because we don't know for 100%. And, you know, that's how scientists and doctors are sometimes, right? Just like way over the top. But lurasidone, which is Latuda, loxapine, which is another old one, I'm going to stick with loxapine, cariprazine, which is Vraylar, and asenapine, which is Safras. These are alternatives that we know are easily tolerated, so people tend to stay on them. People tend to do okay and like them, and they do tend to work, but we've just not studied them that closely. I will say that at times, cariprazine or Vraylar can cause a lot of internal agitation in folks, which another word for that is akathisia. So if you do place somebody on cariprazine, just be mindful of that. I see a lot of that in the work that I do. So I'm hesitant to use it, but a lot of people have a lot of success on that. So just keep that in mind and make sure you follow along closely. I want to say a reason that olanzapine is here, because I know every single one of you, which is Zyprexa, on this talk is saying like, it works great. Why in the world do you have that as a second line, Mindy? Well, what we know is that olanzapine does cause a lot of weight gain. And we talked about some of the reasons why we want to avoid that, both health reasons and social stigma reasons. The other piece of that is if we treat individuals early on with olanzapine, then they will actually gain more weight than they would if we used it later on. And so for that reason, we say, hey, look, let's see, can we be successful using one of these medications? And if we can, great. And if we need to later, fine, we'll use Zyprexa, but let's try one of these first. So for that reason, we say, okay, it's fine to put Zyprexa here as a second line, but it is very effective. Question I often get asked is, okay, Mindy, you know as well as I do that when people come out of the hospital, a lot of times some of our folks, they're on olanzapine, Zyprexa. And it is because it works so well. And if you're a hospital provider, you're thinking, okay, let's get this person better quickly. And so that's why they'll often use Zyprexa. What I do when I get some of my clients who are on olanzapine out of the hospital is once they get pretty stable, I will actually transition them over. Two reasons. One, this is more tolerable for the side effects mostly. And then two, these come in a long-acting option. So does olanzapine, a long-acting option, and we're starting to use that here at MFS, but our hospitals aren't using this quite yet. So those would be the two reasons I transfer people. Less side effects, and also being able to put them on an injection if they so choose. All right. So dosing, right? So it's like, all right, so we know what medications to choose. What does that dosing look like? I'm not going to give hard and fast facts here because you can look them up, and I don't want to make harsh recommendations because I want you and your clients to work together, right? That's the most important thing. If something's intolerable, you got to lower that dose for them. You can't not pay attention to that. But just general principles, right? So in general, persons with early or first episode psychosis, they typically are more responsive to antipsychotic medications. And at the same time, they're more sensitive to side effects. So knowing those two things, what we know is that they require lower doses than usual. So, I mean, I can say for aripiprazole, I mean, sometimes I get by with as low as 5 or 10, risperidone, 2 to 3. So, I mean, we can really go low, and I think that's important because we want to minimize side effects, for our young clients. And I see I have a duplicate slide here. I apologize. I'm not sure why I do, so I'm just going to go on past that. But I see a very important piece is here. I did add the long-acting injectable. I was wondering on my slide where that went, but it's here. So important. I thought I'd put this on twice. So here you go as your second shot of that. All right. So, and I talked about in our objectives is that I wanted to highlight and have an emphasis on long-acting antipsychotic medication and clozapine. Okay, Mindy, what is long-acting antipsychotic medication? LAAM. It's a long word. Well, this is the recovery-oriented and more, friendly version of a long-acting injectable. Long-acting injectable sounds a certain way. We don't like really referring to that injectable. It's very medical. So when I say a long-acting antipsychotic, it usually does come in the form of an injectable. So those are, similar, the same, but just referring to it in a different terminology that I encourage you to use with your clients and colleagues. So let's look at the emphasis on using a long-acting medication as well as clozapine. All right. Before we get to this slide, it's very intense. So I want everybody to stretch a little bit. All right. Big breath. Get your cup of coffee. All right. Take a drink. All right. So bear with me. This is very complicated. Use them, use them, use them. All right. Use long-acting antipsychotic medication. Use it, use it, use it. Every outcome you can think of is better on an LAI or long-acting antipsychotic. The same with clozapine. Folks, if you have somebody and they've had 2 medication attempts, all right, that one of them being one of those second generation for at least 4 to 8 weeks each. Okay, so you've tried one medication for 4 to 8 weeks, didn't really work well. You tried another one, didn't really work well. The client you're working with has had symptoms for at least 6 months. You go to clozapine. You do not try another one. You go to clozapine. All the data we have suggests using clozapine. The earlier, the better. If side effects are intolerable, no problem. Get them back on something that's less side effects. But we really do need to get more and more folks on clozapine. Okay. But definitely, if they're successful with something else, awesome, stick with that, right? But if you do a couple tries and doesn't work, get them on clozapine. So use these agents, use these agents, use these agents. All right. And I was sharing with Michelle that I know a lot of folks in the state are a little bit uncomfortable sometimes with prescribing clozapine especially as an outpatient or prescribing and transitioning from an oral medicine over to a long-acting medication. If you're one of those providers and that's a reason that you've not yet started that, feel free to email me. You know, if you're a provider and you have questions, I'm happy to help. The other plug I'll put in is you can also do a web-based search, so Google, Edge, whatever your preference, and Google this, UNC NCCN. So this stands for University of North Carolina, and the NCCN is North Carolina Clozapine Network. And I actually founded this network and I'm still the director of this. And what this is an expert consultation. It's free, absolutely free. I don't get paid for it at all either. But it's to help people navigate starting clients on Clozapine. And it's a step-by-step, tells you how to monitor it, how do you dose it. You can click on there and talk to somebody within 48 hours if you have questions. I might be that person, so feel free just to email me directly. If you don't like me, that's awesome. I got a lot of that. Don't worry. If you want to talk to somebody else, totally understand. Get on that website and you can connect with one of the experts on there. We also have experts in cardiology, pulmonology, because a lot of times clozapine can, you know, potentially cause heart problems. What if someone has a heart problem? Can you put them on clozapine? Well, we work with a cardiologist. We work with somebody who specializes in you know, cells, blood cells. And so we do have an array of experts that are happy to help. All right. The next slide seriously is a little bit of data, but I'm going to just run through this quickly. Not going to belabor it. So essentially what we have is we have a whole list of medications over here on the left, and anything on the left side, all right, of this line means that medication works really well and even better than just oral Zyprexa. The stuff on this side of the line says, yeah, no, using oral Zyprexa actually works a little bit better. And we just talked about earlier how Zyprexa, right, works super well. And so everything's sort of measured against it. So what I want to highlight is, look at clozapine, right? Far and beyond, better, way kind of out here by itself, right? Further out here. So again, works the best. But the other piece I want to point out to you is boom. Right? What is every other thing listed at the top? It's LAIs. LAIs of every type before any of the other oral medications. So again, we really need to get people on a long-acting antipsychotic medication. Don't pay attention to this polytherapy. We shouldn't really be doing that. That's when you prescribe two. It's fine to prescribe two only if you're not successful with one and only if you're not successful with clozapine. Okay, see, Michelle said it wasn't too bad. It wasn't too bad of a data slide, right? Okay, and the most important part, sort of going back to what we talked about earlier, is we really want to use that person-centered approach. We really, really want to emphasize and use this. And what we do want to do as providers, as peers, as therapists, as counselors, is we do want to share and explain the disease model of psychosis. And I sort of put that in parentheses because I don't really like using that term. And at the end of the day, it is what it is. And the reason that it's important for us to use this model and explain what happens in the brain, what are some of those changes? Why does medication help with those changes? Why does resiliency help? Is because a lot of times our younger population, they underestimate risk, right? We all remember what it was like to be young and like you're invincible, you can do anything, nothing's going to happen. And so because of that, when we pair this sort of understanding of, look, this is a disease and what it looks like, it helps our younger folks to impart some logic and better understand the disease frameworks, all right? And what we know is that when individuals have a lack of understanding of their illness, then it's a predictor of not sticking to medication and what we call prognostically poor outcomes, meaning a person won't do as well later in life. And so not only is it important to get adherence, but it does share with us that we know it's important people understand their illness because they'll actually do better longer term because of it. And we want to educate fully as to the why of the treatment team's recommendations and choices. And again, this is treatment team, right? This is a team approach. So why are we saying this type of therapy? Why are we saying peer support is fundamental in working with our young population? And why are we saying this particular medication is maybe more helpful than the other one? This is what I'm recommending, or, or putting options out there. And what we really want to do as well, using this person-centered approach, is for us to understand the clients and their natural supports, values, perspectives, cultural norms, because they may be different than yours. Please always be mindful of that. And what the clients and natural supports treatment goals and recovery goals are, because this will greatly determine and help us guide our treatment so we can match up with our clients' values, perspectives, culture, and treatment goals. And then last and most important thing, right? Preferences, right? We got to do what it is when they make an informed decision, and we just help guide them in that process. That's all we do. And it's the client's decision to treat however and whenever and as frequently as what the client wants to do. We can guide them, but it's ultimately their decision. And going to continue on with using a person-centered approach is what we also know based on the data, the research, and what I've seen in my own practice is that when clients have a feeling of a lack of autonomy, that typically is a driver of treatment non-adherence. And it sort of think about this age population, right? So folks are really wanting autonomy. They're coming into their own and they're being told, right, they have to do this particular thing. Well, when an approach is taken that way by a provider or a treatment team member, a lot of times that's going to lead our client to not actually engaging in that treatment. And I've had this happen to me. I've times found myself being too paternal/maternalistic, whichever word people would prefer to use in that. And it backfires, and you got to make sure that you're giving individuals autonomy and agency. And again, research and experience has shown that when we do use a shared decision-making, it leads to greater client satisfaction. That's the utmost importance. And so what are the downstream effects of greater client satisfaction? And I would pause and ask people to put it in the chat, but I want to be mindful of our time. It is that when our folks are happier and more satisfied with the treatment they're receiving, they're going to be more likely to stay on it, so have improved adherence. It's going to have a greater reduction in their symptoms. It's going to give them a greater quality of life, and they're going to have less unmet needs. And so a lot of these sort of scientific outcomes, right, that we strive for, those of us, who are our providers or social workers, or therapists or peers, we can get these by simply using a shared decision-making and client-centered approach, which is the most important thing we can do. So with that, I know everyone is thrilled because we're on the summary slide. To remind everybody, the best treatment for a client is the one that he, she, or they are willing to accept and willing to adhere to and choose. Our goal as providers of treatment team is to lower stress and vulnerability and increase resiliency through all of the different modalities we talked about. We want to target the symptoms of anxiety, depression, mood instability, and trauma in individuals who are at risk for developing a psychotic disorder. And again, we know that using an antidepressant, SSRI, is a good option to do. Of course, if they have mood instability, we would want to use a mood stabilizer. And in those with first or early episode psychosis, treatment with antipsychotics that have high effectiveness, low side effects are recommended. And to be more granular and specific than that, risperidone, haloperidol, and aripiprazole. Long-acting antipsychotic medication and clozapine. Use them, right? And I will end on that. If anybody does happen to want the references for the data that I've used, happy to provide that to you. Just did not want to bore folks with that or put it on the slides, but happy to provide that. And I will stop now and open up for questions.
Terrific. Thank you, Mindy. And if you want to stop sharing your slides, then We can all be here on the screen. So questions from folks. I see some. From Nicole Olanzapine, have used first line for active SI, so suicidal ideation, dark thoughts, short term to stabilize. SI lithium can take a while to function. Is this appropriate?
Typically not using olanzapine for individuals who have suicidal ideation as a first line. If they're older and have had exposures to other medications, that's fine. Absolutely, lithium would be the go-to for that if somebody has significant suicidal ideation. Clozapine has the best evidence for suicidal ideation. So if somebody is skipping through those trials, I would go to clozapine before olanzapine because you get both of those things, better treatment, as well as the negating the suicidal ideation. But great question, Nicole. Thanks for asking that.
And this is a two-part question from Jeff. Given increased antipsychotic sensitivity in FEP, first episode psychosis, do you notice changes to the therapeutic range of clozapine and FEP?
Oh, what a good question, Jeff. I wonder if that's Jeff Fetter. Whoever, Jeff, thank you. That's great. Great question. I don't. I wish I could say yes. So what Jeff is asking, saying that, okay, so the folks who require lower doses of medications, when we judge how much medication is in the body for clozapine, is their clozapine amount less than what adults are? And Jeff, typically I kind of see that, but not substantially. So I know we all target for 450 or above. I can start seeing response. I have seen response at about 300, but usually it's going to take that level before I start seeing anything. The data on it is kind of mixed. There's some data that says that you can get by with lower levels. I'm probably like a lot of you on here and you as well, Jeff, that I'm going to target the symptoms and the function. And so when someone tells me they're doing better, their symptoms are less, they feel better, and they're doing better in school, then at that point, I'll probably get a level, right? If I don't think I'm overshooting it. So I want to make sure I'm never too high, but if I'm only 200 milligrams of clozapine or 100 and they're sailing, awesome, I'm going to stop. I'll get a level just so I can see what it is. So that way I can earmark it in the future to make sure I know what I need to target in the future. So that's how I approach it. But as far as the hard facts, typically it's going to still be a higher level and no data to support one way or the other. Good question.
And the second part of that was, if so, does clozapine toxicity look different in FEP patients compared to other psychotic populations?
Another good question, Jeff. It does not. However, when I think adult patients, or chronic individuals, we typically see, greater than a dose of 650 conferring seizure, and then doses or levels greater than 1,000 really having substantial risk of side effects. We do see that side effects happen a little bit more frequently, but not those neurotoxic side effects that individuals are going to develop. I definitely tend to see that there's a higher metabolic adverse effect in the younger folks than I do with the more chronic population. But again, I don't know if that's from the priming effect of having something like olanzapine or clozapine so early on, whereas a lot of the adult patients have had, unfortunately, 5 or 6 med trials before they've gotten to clozapine and therefore have sort of that priming effect of where it's not going to be as bad metabolically.
And Mindy, can you just remind us why some prescribers have been reluctant to prescribe clozapine?
Absolutely. Clozapine appears very scary, right? So for a lot of prescribers, it's, gosh, I have to do this blood monitoring. I have to check all these different side effects. Clozapine can cause, infections in the heart. It can cause the heart to enlarge. And all of these side effects that we as providers have to be made aware of for safety. The odds, though, of someone dying from agranulocytosis, so those low blood cells, because of clozapine, is less than someone dying from the gastric hypomotility, so the constipation that clozapine causes, right? And so I think putting that risk in perspective is really important. And sometimes when I share that, people become a little bit less hesitant to prescribe it. We do have to be diligent about monitoring the side effects, especially early on with the heart. But that's something that can be done inpatient. And if anybody wants to do it outpatient, we do them here. I've done them in the past. Really happy to help. But I think clozapine is sort of made a little bit scarier, if you will, than what it actually is.
Mm. Yep, and I have a family member who's doing beautifully on it.
Ah, that's great, Michelle. That's great.
One of the things you said was the disease model of psychosis, and I do a lot of education around early psychosis, and I'm always saying this is a medical condition. It's a medical condition,
That's
right?
great.
So yeah,
Abs-
thinking about that view of it. My loved ones, one in particular, has a health condition. This is a health condition. That's what it is. Because I think that word disease can have a negative connotation too. Yeah,
Yes.
yeah.
100%. I hate that word disease model. I completely agree
Mhm.
with you, Michelle.
Yeah, yeah. And I was just thinking about prescribing. It's an art. It's an art form, right? We would like it to be science and clear cut. You were talking about the lack of autonomy, and I was thinking of my son saying, I'm a guinea pig. That's what I am. I feel like a guinea pig. So that, yeah.
Right. And yeah, Michelle, I hear that a lot, and have heard that from other providers as well. And
Mhm.
that just makes us know that we're not quite doing it right. We're not
Mm.
quite doing that part right.
Yeah. So any closing words for us, Mindy? Anything you would like this audience to take away with them?
Um, yes, thanks, Michelle. For the providers and for those who work with individuals who have had early psychotic experiences or their first psychotic experiences, um, long-acting antipsychotic medication, quickly move to clozapine. If you're working with someone and you're not the provider and you see that this person is on a medication and they're struggling to remember to take it every day or having other challenges, ping that provider and say, hey, such and such, have you ever thought about putting them on a long-acting? Or if you're working with someone who's had a couple of tries of antipsychotic medication and they're just not happy with where they are and you're seeing that they're not doing well, again, mention to that prescriber, hey, have you thought about clozapine? Because I can say from a prescriber's perspective, sometimes we get so wrapped up in things, we don't even think about it, and forget. And so having someone remind us is extremely helpful. And the other thing, Michelle, is just that person-centered. The best medication is the medication that someone's willing and wants to take, period.
And sometimes it isn't clozapine, and sometimes it
Right.
doesn't work, right? As a disclaimer.
Absolutely. Yeah, thanks for bringing that up. It's not the miracle for all, but it's something that we have to try.
Great. Thank you so much, Dr. Asbury. We appreciate you joining us today. And just a reminder, a recording of today's discussion will be posted on the education page of onwardnh.org. You'll receive an email in the next couple of days, which will include links for the website along with that evaluation. Once you've completed the survey, you'll automatically receive a certificate of attendance. For questions or comments, please reach out to me. Any questions for Dr. Asbury, you can email me at mwagner@naminh.org. And we look forward to seeing you next time. Until then, take care and happy holidays.
Bye, Michelle. Bye, Meredith.
Bye, all.